All right, we're going to go ahead and get started. Folks will be continuing to join us, but on behalf of Catholic Charities and our social justice advocacy and engagement team, welcome everyone. My name is Mike Rios-Keating. I am the social justice education manager at Catholic Charities, and we are so grateful that you are here tonight. And really, I am thankful you are here. There are many ways that you could be spending your evenings, and you chose to join this discussion. And on top of that, 2 years into a pandemic and Zoom fatigue really is a thing. So thank you for being here. I want to thank United Healthcare Group, who graciously sponsored this event, and to Hennepin Health, mHealth Fairview, Person-Centered Housing Consultants, and Carleton County for their partnership in making this event possible through our guest speakers tonight. And lastly, to my colleagues at the Social Justice Advocacy and Engagement team at Catholic Charities. We'll continue to talk about our work throughout the night, but you can learn more about our advocacy work by logging onto our website at cctwincities.org or texting the word voice to 50457. We'll put that in the chat for you, but if you text voice to 50457, that will bring you to a petition around the power of home, and that is a way that you can get involved in our advocacy work. So a few housekeeping items before we get started. If you have miraculously made it this far into the pandemic without using Zoom, or if this is still new to you, that is okay. I just ask that everyone finds their mute button as we go along. It's the little microphone button in the corner or in the top of your screen. And we just ask that folks stay muted until the end when we have some time for Q&A, that you can manage your own microphone as we continue throughout this evening. And I also invite you to use the chat as we are going along. If you have questions that come up throughout the evening, I invite you to put that. If you think you might forget it by the time the end of the event comes on, go ahead and put it in the chat, and we'll make sure it gets asked at the end of the event. And on the other hand, if you've become a Zoom expert, you may be wondering why you are in a Zoom meeting and not a Zoom webinar, a meeting in which everyone has control over their microphones and you can see everybody who is here on little screens, versus a webinar of just guests and panel speakers. And that was an intentional choice. You know, one of the gifts of community education, which is my field of work, and one of the gifts of community education as a practice is being able to learn from each other, recognizing that your neighbor has wisdom and expertise in their own experience. That while gathering information and hearing from experts and leaders is really important, you are experts in the way that your life has touched housing and health as systems. The Social Justice Assembly, which is where you are tonight, is a long-standing tradition for the Office for Social Justice that started as a way to bring advocates together from across the metro area who might not otherwise meet each other, to bring them together to break bread. Oftentimes there would be food, discuss issues, get updated on Catholic Charities advocacy work, and it's evolved into exploring specific issues like our topic tonight, issues that impact our clients at Catholic Charities. Today in the audience, we have service providers, allies, advocates, lawmakers, folks who have lived some of the difficulties in this intersection. And one of the gifts of the virtual side of things that, you know, now that we have gotten into this in a virtual way, we were able to extend the conversation to greater Minnesota. So folks are logging in from up north, down south, out west. And so we get to spread this community discussion a little bit larger. So that choice to make it a meeting was intentional. You know, though we cannot gather in round tables and share soup together, we wanted to make this as communal as possible. And so I invite you to make this as interactive as you feel comfortable. And so to that end, I invite you to use the chat when you have questions. If you see somebody here that you know that you haven't seen in a while, you can direct message them in the chat. And if you are a social media user, I encourage you to join the conversation using the hashtag RxHousing, prescription housing, and our Twitter handle is cctwincities.org. And so that's enough housekeeping for now. I want to quickly introduce our president and CEO, Michael Gore, for a short welcome.
Yeah, thank you. Thank you, everyone. Let me just echo Mike Rios' comment and say welcome, good evening to every one of you joining us this evening. And a special thank you to United Health Group once again for sponsoring this event. And also thank our moderator and panelists as well. And thank you very much for lending your expertise for this evening. So thank you so much once again. And for us in Catholic Charity, this topic is super important because this is work that we do every day. And I'm blessed to lead amazing staff that offer housing and emergency shelter and direct services. Every year we serve over 23,000 community members, and we serve over a million meals any given year. And we are overwhelmed sometimes, and especially during past 2 years with COVID. But we have a resilient group of folks working with us every day, showing up, doing the work. And so I'm so honored and pleased to lead that group. To that end, for us and our work and all of you who are here today is that we see housing, this issue as so super critical. The housing stability is a fundamental to overall well-being for our youngest community members that we provide services to, our most senior citizens that we provide services. We know that the impact of emotional behavior development and also the traumatic experience that lead to adulthood that directly connects to our housing is a lack of housing stability. So this subject is so super critical for the equity work that we're engaged in, the social justice work we're engaged in Catholic Charities. To that end, one of the work also led by a social justice team is advocating at the state, making sure that critical investments are funded, that we advocate for underserved community, we advocate for our community members who might not have the voice. So we do that every day, and we encourage all of you to follow our work and join us in advocating at state level as well. So once again, welcome. I hope you enjoy this evening, and thank you so much for being with us. Let me kick it back to Michael.
Thank you so much, Michael. As Michael mentioned, Catholic Charities work is certainly wrapped up in this intersection of housing and health. We hear countless stories, both successes and stories of struggle. And in fact, one of the many times our team has found themselves in working within these systems and how they influence each other was just last legislative session. There is a permanent supportive housing program called Housing Support, and tenants had been burdened by a specific absence policy, which limited the amount of time an individual who was using housing support could be absent from their residence to no more than 18 days, regardless of their circumstance. So, or cause for that absence. So imagine for a tenant requiring hospitalization for a chronic medical condition or illnesses like COVID-19, or for longer term substance or mental health inpatient treatment, it meant that many were facing the difficult decision of choosing between housing and health. And so Catholic Charities worked with lawmakers to introduce legislation that would waive the existing 18-day absence limit for housing support recipients who were in need of healthcare treatment. And that bill had overwhelming bipartisan support and was backed by cross-sector leaders. And so as a part of the last special session last year, lawmakers revised that housing support absence policy to allow tenants up to 92 days per calendar year for the purposes of seeking healthcare treatment. That's, of course, just one of the many ways, as you'll hear tonight, that these systems intersect and are wound up with each other. But it's a fantastic example of what can happen when stories are shared and the community comes together to learn about these barriers and to work to make a change. which is why we're so excited to have this space tonight to continue the discussion with a panel of amazing Minnesota leaders. So it's my pleasure to first introduce our moderator, Dr. Danielle Robertshaw, who will be kicking things off with a short primer on tonight's topic. And I'll ask that you hold your verbal questions to the Q&A portion at the end, but certainly if you feel like you may forget them, you can put them in the chat and we'll collect them. But we will save them until the end, and so we'll stay muted until that time as well. So Dr. Danielle Robertshaw is the Senior Medical Director of Population Health at Hennepin Healthcare. She supports the development of population health strategy and capabilities, as well as operations of services that focus on at-risk populations across the care continuum through her leadership role in community connections, care ring, and Hennepin County Public Health Clinical Services, including healthcare for the homeless. Before joining Hennepin Healthcare in 2012, she held leadership positions and provided primary care in a large federally qualified health center and healthcare for the homeless in the Mid-Atlantic. Her clinical practices focus on primary care for adults experiencing homelessness with complex medical and behavioral health needs. She enjoys teaching pre-health students and health sector learners. Without further ado, Danielle, thank you so much for being here. Take it away.
Awesome. Thank you very much, Mike. I appreciate it. So give me a second here. I'm going to share my screen, and Mike, if you give me it works, I would be appreciative. Let's see. How about now? Mike?
Yes, you are good to go.
Very good. Wonderful. Well, thank you for that introduction. I'm super excited to be here. I have to admit, I'm not someone who enjoys public speaking, but this is obviously a topic I'm incredibly passionate about. As noted, I've kind of focused my career for the last 20 years on serving individuals, adults, and families, and then populations experiencing homelessness. So certainly something I'm very, very passionate about. So tonight, I really think this is an awesome topic around how we kind of figure out the intersections, right? So if I think about, I am someone first and foremost who sees myself as serving those who are experiencing homelessness. And I fundamentally believe that housing is a human right. And I strongly believe it's not just housing. I believe that it's housing that is accessible, affordable, safe, and culturally appropriate. And I think these are sort of the values I live by. However, I'm also a doctor, right? So I also believe healthcare is a human right. And I believe that people similarly should have high quality health care. I'm just getting a little background, high quality healthcare, and that healthcare should not be a privilege, but it is actually a right for all. And I think that healthcare should be, again, accessible, high quality, culturally responsive, and that seeks to innovate and tailor care to the individuals and populations that it serves. So I think about the things that come to mind, at least for me, when I first start to think about healthcare, and maybe many others. Maybe it's a stethoscope, right? I'm a doctor, so I think about stethoscopes. Maybe it's vaccines. We're in the middle of COVID, and we've all heard a lot about vaccines. Maybe it's a hospital or a clinic. So what are the things that help keep people healthy? Oh, and can't forget the healthcare providers. I'm a doctor, right? So doctors and nurses, certainly important when we think about healthcare. But I guess a question to me comes about when we start to think about prescriptions. We do for medications. We do for a variety of medical equipment. But what about housing? And this is tonight where we're really going to focus. And I'm super excited to have our panel here and be invited to host this or moderate, thinking about how is housing intricately related to healthcare and vice versa, honestly. And this is an organization, the National Healthcare for the Homeless organization, a slogan that we have lived by for 30 some years, and super excited about this. You can see a variety. We have a button, a bumper sticker. We certainly have a tote. But if you're someone like me, who can't get their slide going forward, and you want to just kind of keep your message simple and maybe uncluttered and clear, housing is healthcare, and both are human rights. And certainly this is not a new concept. This is actually something I cut and paste from 1948 where the United Nations in their Universal Declaration of Human Rights pulled out the fact that everyone should have a right to standard of living that's adequate for health and well-being, and includes things like food, clothing, housing, and medical care. So I think this is just kind of letting us know that these are not new concepts, but we're certainly excited that we're being able to pull them together in a little bit more of a way that helps us support together ending homelessness. So one thing I also want to say, and I spend a lot of time teaching, as noted in my introduction, medical students and learning residents and a variety of different health sector learners who are probably born at best in the 90s. And homelessness has been visible their entire lifetime. And I think I just always step back and say, is this okay? Is this normal? And I think we need to just acknowledge and think about the fact that it is not. It is not acceptable and it is not normal. And that's really important to me. So tonight, I'm just going to give you a quick primer, 101. We're going to talk about how we define homelessness, think about some of the causes, look at how it impacts health and vice versa, and then consider how we might embark on some non-traditional partnerships in order to end homelessness. So I'm just going to throw these down, and I don't expect you to read them. It's a mishmash of, we have a lot of federal alphabet soup. We have HUD and HRSA and SAMHSA and a variety of others whose initials I have a hard time remembering. We have the Hearth Act, and then we get local jurisdictions. And honestly, at the end of the day, as a healthcare provider, what I've seen is data that shows me that any type of homelessness is bad for your health. So lax housing, that seems fair. Those who are doubled up or couch surfing, so definitely thinking about the instability of it. Adequate is super important. I did spend 3 years in a town in the mid-Atlantic that had, unfortunately, a lot of boarded up houses where people were essentially squatting. And so I think about the fact that you had no electricity, no running water. Is that adequate? It is not. If I think about the health ramifications for that, certainly fleeing domestic violence, but at the end of the day, honestly, it's just a recognition of the instability from a healthcare perspective. So we have a federal mandate that asks us to do a head count of people who are experiencing homelessness every year, but in Minnesota, we are additionally very lucky to have Wilder. They do a more in-depth survey every 3 years, and I will say it's really hard to count people experiencing homelessness. You don't just put up a sign that says like, hey, come stand here so I can count you. But they've developed over time a very robust system that not only helps us understand the numbers, but who the people are behind those numbers. So thinking about the ages and the health conditions and the mental health needs. So we have very robust data that every 3 years gets published. This most recent data is from 2018, specific to Minnesota. We'll expect the 21 data, probably mid-year, but thinking about this, we have seen a variety of bumps and curves over time in Minnesota, but unfortunately between 2015 and 2018, we did actually see an increase in the overall number of people on this one night experiencing homelessness. So just a couple of things to help us understand who are the people and kind of think about how we put a face behind these numbers. Roughly 46% are either children or youth under 24 who are independent. And that's kind of sad and scary. But I also think the numbers of adults who are older, over 55, is actually up almost 25%. And to me, that's also sad. There's nothing about homelessness that isn't sad, but when we start to put behind the numbers a little bit of detail about who is experiencing it, it becomes a little more real. I think we always see nationwide, and Minnesota is no exception, disparities based on race and ethnicity. So here in Minnesota, African Americans and American Indians are unfortunately overrepresented, as are youth who identify as LGBTQI. So quickly, just a high-level view of systemic causes of homelessness. I think about poverty, and poverty has so many pieces that play into it. These are just a few. Certainly, we've over the last 5 to 10 years noted in a lot of the ways that our policies have thought about wages as a complete discernment between minimum wage and living wage. And this is really super important. Most recent data in Minnesota that looked at a mom and 2 kids said somebody would need to make almost $30 an hour to be able to afford basic living things, including transportation, food, and housing. And we're not talking about a large palatial estate. We're talking about basic needs for everyday living. Lack of affordable housing. And again, I just want to highlight the fact that affordable is super important, but along with affordability needs to be the fact that it is safe neighborhoods, that it's adequate. So we're not dealing with additional issues around mold, that we have things like electricity and heat. And again, pointing out some of the long-standing racism and racial disparities that we've experienced across the centuries. These certainly are things that have piled up and added to all these different pieces. And lack of a safety net. We have policies that have been put in place and set in motion over decades to actually centuries that have systematically de-invested in very crucial pieces of our safety net system as a nation. And poor health. So poor health puts one at risk for homelessness. About half of personal bankruptcies in the US are caused by health problems. And too often and too quickly, bankruptcy leads quickly to eviction and homelessness. So certainly something that we need to keep in mind as we're thinking about sort of chicken and egg. It plays both ways when it comes to both poor health and homelessness. So just a quick check on timeline for a variety of different countries that have said that healthcare is a right and actually lived up to it. Germany was the first country in 1883 to afford the entire country, saying healthcare is a right and we were going to provide it for everybody. In the US, we've taken a couple of stabs at it in the 1940s and again in the mid-90s. And I am super excited that we passed the Affordable Care Act in 2014. It was a step in the right direction. It is not complete, but here in Minnesota, we're fairly progressive overall as a state, and we had actually expanded healthcare to adults without dependent children who are poor prior to that. But Medicaid expansion here in the state has certainly helped us to bolster that and continue to do really good things to support people in their health. All right, so maybe you're thinking, hey, she's a doctor. Does housing status really matter? And I spend a lot of time again teaching, residents and medical students. And I think one of the interesting things to me is I remember back in my day, we're talking a couple decades ago, seeing this particular graphic around social determinants. And the point 20 years ago from a learning perspective was really, hey, doc, don't be disappointed if your patients don't get healthy, even if you give them the best possible care. So really focusing on the left hand of this. Your work only accounts for 10%. I think the way we've flipped this these days is really a little bit more around what are the other factors? And so pointing out the fact that this entire left side of this diagram is super important, that all these other factors not only are important, but vital for us to think about as we consider healthcare. So social determinants of health. And I love the WHO or World Health Organization's definition. It helps to frame not only what are those conditions, but also the fact that these things are unfair and avoidable. So 2 decades of learning. What have I figured out? That there's a lot of great information out and about, and that I believe everything that's been published in the last 30 years. Homelessness causes health problems. So we have had multiple bouts of tuberculosis in the shelters, active tuberculosis, over the last few years in Minnesota. Flu, if one person gets it in a shelter, it tends to spread very quickly. And certainly weather-related conditions, things like frostbite and hypothermia. So existing illnesses, right? So if I get flu, I get to come home and sleep in my nice warm bed with somebody helping me get my medications and food and all these things. But if I'm homeless, I'm more likely to progress to a pneumonia and require hospitalization. Cuts easily become infections, and that can lead to amputations and lifelong disability. And certainly, sort of the chaos of daily living and competing priorities complicate treatment and continuity of care, and is a risk factor for early death. We've had multiple studies over 3 decades that show us that the average age of death for somebody who is chronically homeless is around 47 years old, despite an average life expectancy in the US closer to 80. And I'll just note, in 1900 in the US, the average life expectancy was 48 years old. So the patients I care for have all the same health conditions as their house counterparts, right? Asthma, diabetes, high blood pressure. However, the patients that we care for also tend to get sicker at younger ages, are often diagnosed later in a disease course, and are likely to have higher rates of uncontrolled medical conditions. So a few years ago, I turned a certain magical age. Even though I wasn't having symptoms and I didn't have a family history, my doctor tested me for diabetes during my annual well visit. That's not often the case for our patients experiencing homelessness. They're often presenting to the emergency room with out of control diabetes, having never been diagnosed with it in the first place, and leading to a lot of health complications. This is a quote, one of my favorite people in the world, Dr. Jim O'Connell, who was one of the first in the field and is still in the field in Boston. And he wrote an article called Dying in the Shadows, Challenges of Providing Healthcare for People Experiencing Homelessness. I changed the wording a little. But he talks about how certain conditions such as whooping cough and vitamin deficiencies and lice infestations harken to earlier centuries, and that those caring for this population must merge medicine and public health. Tuberculosis and HIV are endemic. Outbreaks of communicable diseases such as influenza and infestations are ubiquitous in shelters, and trauma and violence hound homeless poor people. And of course, in the last few years, COVID. You know, this is not something that we have decades of literature on, but I will say Minnesota was incredibly progressive and one of the first states to actually start to capture information around COVID and its impact to homeless populations specifically. So it's probably very small to read, but I will say the red bars are people that are not been identified as homeless. The darker blue or black bars are those who are homeless and likely sheltered, and those in the green bars unsheltered. So the top bar was looking at percentage of people hospitalized due to COVID. And we can see that the numbers of those who are unsheltered and those who are sheltered far and away outstrip those who are not homeless. And the underneath is those who required an intensive care or ICU stay. So those who are more sick because of COVID. And so this has been groundbreaking information, and there's an article coming out about the amount of work that's been done in Minnesota to help to capture this information and share it. So I'm a doctor. I work at a health system. What is my job? What is my role to help solve this? And how do we bring multiple sectors together? And this is where I'm super excited for tonight's conversation, right? So how do we address something that feels unsolvable, and it feels more unsolvable alone? I don't have a bucket of apartment keys in my clinic office. I certainly wish I did. And I can't yet, but someday my hope would be that I can actually just write a prescription for housing. I want to quick highlight some of the ways that we start to think about how to bring different sectors together. And to me, medical respite, otherwise known as recuperative care, is one of those ways. Because I don't have that bucket of apartment keys in my clinic, one of the things we can think about is how do we begin to bring different subject matter expertise together from those different sectors. And so if you're not familiar with medical respite, this is the national model. I had the privilege of, in my first job, working at one of the nation's first that opened in 1984. It's essentially somewhere that if you are too sick to be on the street or in shelter, but you're not sick enough to require hospitalization, that you can be inside 24 hours a day, 7 days a week, that at a minimum you have meals provided, and ideally medical care and other support services or shelter services. And we're super excited. Over the last 3 years, we've worked really well with Catholic Charities and a variety of other partners from Hennepin County and Hennepin Healthcare and health systems across the state to figure out how we start to understand how health systems can contribute and pay for this. And passed in legislation last year, the ability for our state partners who work with Medicaid to begin to think about creating a benefit set for the services for this. Historically, over these 30 years, these have been things that have been patchworked together with a variety of things, but the outcomes here, connection to housing, improved healthcare, improvement in understanding the health needs and medications and literacy and connecting to healthcare and behavioral health services. We have decades of data that says this is just an amazing model, and it's somewhere that we know shelters are often overwhelmed by the clinical complexity of those who kind of cross their threshold. Hospitals aren't equipped to help people find housing for the amount of time it takes. And so this is a really nice space where some of these sectors that we work in can come together and say, hey, we can all contribute and really make an impact. And this is a slide I always leave the medical students and residents with. You know, at the end of the day, it's really easy not to see homelessness, and it's really easy not to see it on the street, and it's really easy to drive past it. It's also really easy to miss it when you're caring for people from the healthcare side. And so I think just understanding that behind every person experiencing homelessness is somebody who has a story and deserves dignity. So one of my favorite slides. So that is the end of my primer, my 101. So I appreciate the opportunity to share. I'm going to pivot now and bring forward some of my fantastic colleagues here that I've just learned recently, have just met recently, after I figure out how to end that. Yeah, okay. Well, technical difficulties, we'll keep moving. We have a really exciting panel tonight. Certainly 3 experts here. So Brian Bozeman, Brian is the owner of Person-Centered Housing Consultants. And Brian works tirelessly with his agency around housing stabilization services dedicated to providing culturally competent service to those in need to connect to housing stability. He has been serving unhoused or displaced individuals for nearly 20 years, including experience in emergency shelter services, housing navigation and support services, rapid rehousing, outreach, and coordinated entry assessments. Prior to funding the Person-Centered Housing Consultants, Brian worked as a program coordinator at Catholic Charities and has worked with partners including Ramsey County, the City of St. Paul, Simpson Housing Services, Hennepin County Shelter Efficiency, and Coordinated Entry of St. Paul. Thank you, Brian, for joining us tonight. We also have Dave Lee. Dave is the director for the Carleton County Public Health and Human Services. He's also the current chair of the Minnesota State Advisory Council on Mental Health, was initially appointed by Governor Dayton in 2015 and then reappointed by Governor Walz in 2019. Dave recently led the Advisory Council in organizing and sponsoring the annual mental health awareness at the Minnesota State Fair and represents counties at the counties on the Minnesota Suicide Prevention Task Force. His areas of interest include integration of behavioral health services with primary care and medical settings, and coordinated suicide prevention services and telepresence. And last, Diane Tran. Diane is the System Executive Director for the Community Health Equity and Engagement at mHealth Fairview. She previously served as System Director of Neighborhood Integration and Community Engagement at Health East. Prior to that, Diane provided strategic community engagement consulting services as a Senior Project Manager at Grassroots Solutions, and is also the founder of Minnesota Rising. Her previous work experience includes directing Minnesota field activities for the Pew Charitable Trusts program to advance federal clean energy policies and coordinating a local public health advocacy campaign to pass the Freedom to Breathe Act of 2007, a statewide smoke-free workplace policy protecting Minnesotans from the harmful effects of secondhand smoke. And Twin Cities Business Magazine named her one of the 100 Minnesotans to know in 2015. Thank you, guys. I'm so excited to have you all. I appreciate you joining us tonight. So we're going to start with kind of a broad question to help people understand and learn more about you and what you feel passionate about in this topic. Each of you has a particular lens to this topic, to the intersection of health and housing. Can you each share a little more about your work and what housing as healthcare means to you in your field? Diane, I'm gonna call on you first.
Wonderful, thank you. Well, it's a pleasure to be here all with you this evening. And thank you to Catholic Charities for hosting this event and Dr. Robertshaw for that primer. So I certainly enter this work, as you heard, through the perspective of a health system. mHealth Fairview is a partnership between Fairview Health Services, the University of Minnesota Physicians, and the University of Minnesota Medical School. And so as we think about how it is that we combine that history and, family and community medicine with the innovations coming out of the University of Minnesota and the research, certainly housing is an issue that confounds us. It's a complex built by years of history and policy and other kinds of decisions that, as we think about the ability to address the issue, really does require various stakeholders coming together and people passionate about creating change together. So I'm very heartened by this group this evening. I do approach it recognizing that as we think about health, research continues to show that zip code is increasingly a greater predictor of health outcomes than genetic code. And so that means that where we live, work, learn, live, play, or pray has a significant impact on how well we are. In fact, 10 to 20% of our health is impacted by the care that we receive inside of hospital and clinic walls, and 80 to 90% is these things that comprise our daily lives if we have stable, secure, safe, affordable, culturally responsive housing. If we are able to feel safe and connected, trusting that our neighbors will support us in times of need, that we're able to get healthy, nutritious food that supports us, that reflects our culture and what nourishes us. Our ability to maintain and sustain employment and to progress in our education, these things that create vibrancy in our lives, in our families, in our communities. And so as we think broadly about those issues and how it is that we ensure a community and resources that reinforce creating that health and well-being for our community, and looking particularly at issues of inequity and disparity, housing certainly is central to that. We conduct a community health needs assessment as one way in which we try to be aware of and in conversation with our community, really hearing from data, from stories, from community leaders, and from residents, what it is that's arising and needs to be addressed, and how we can be one part of that solution in partnership with other organizations and our community members. And certainly housing comes up time and time again, and it's inextricably linked, of course, to mental health and to food and food access, to transportation. And so wanting to, from the perspective of the health system and these social determinants of health that do indeed impact our ability to have positive healthcare experiences and outcomes, recognize it's a very large picture, and that we are eager, certainly through some of the programs and responses and the ways that we show up in community and serve on different boards and conversations to advance work around health equity and housing, to do that in a way that does bring forward the resources that are required to address this really large scale, multifaceted issue. So that's what I would bring in, is a global picture as we think about physical, mental, emotional, and community health, particularly with a lens on health equity. So with that, I'll hand it over to one of my fellow panelists.
Thank you, Diane. That was great. Dave, you're next.
Thank you. Thanks for the opportunity to join you this evening. As was mentioned earlier, my primary role in Carleton County is Director of both Public Health and Human Services. And the mission of our agency, like many other county human services and public health agencies, is to promote the health, safety, dignity, and self-sufficiency of individuals and families and communities. Well, without adequate housing for people in our communities, we are ill-equipped to be successful in our attempts to be able to promote health, safety, dignity, and self-sufficiency. Whether we're working with vulnerable adults, people with mental health or substance use disorders, individuals with disabilities, dealing with child protection situations, or working to transition folks out of the justice system, housing limitations have led to a reduction in successful outcomes in no matter what we're trying to accomplish. From a public health director standpoint, lack of adequate housing has been identified as one of the top 3 health issues for our communities, as reflected in our most recent community health assessment. As we review data from multiple sources, including Minnesota Child Welfare Report, Bridge to Health surveys, Minnesota Health Statistics, and the Minnesota Student Survey, community leaders in our area have identified lack of affordable housing to be anywhere from a moderate to severe problem. It's hard to, as has been already stated, it's hard to be healthy when you have no safe, predictable place for your place for your food, medicine, belongings, in addition to not having some sense of control over your environment. Unfortunately, we see the lack of housing negatively impact the health of our communities every day. So I know we have a lot to cover, so I'll leave it there for now.
Thank you for that. I appreciate it, Dave. So Brian.
Hello and good evening. First off, I want to say thank you for allowing me to be here on this panel today. And after listening to my two colleagues here on the panel, I agree with everything that they stated. I like to look at this issue of health and homelessness as a large one, and a lot about like the first thing that comes to my mind in the years of working in the field is, where do you keep your medication? The trauma you go through every day when you get up in the morning, and where am I going to get something to eat? Where am I going to stay warm? Just those things that someone who has a place to go to and return to every night does not have to worry about, and how those things impact, like Diane said, somebody's physical health, somebody's mental health, and somebody's chemical health. All those things are affected when you don't know where you're going to stay each night. And just the day by day, like, is my stuff going to be there when I get back? Am I going to be able to get in line to take a shower enough? I'm diabetic. Are they going to have some food I can eat that doesn't spike my blood sugar? I mean, there's all kinds of things that come into this when you speak about health and not having a place to call your own. And then on the brighter side is all those things that you can take care of once you have your own place. You can, keep your medication. You can shower as need be. You can cook your own meals that good for your dietary reasons. You can have PCA services. There's a gamut of things that you can improve your quality of health by having a place to live. And then when you don't have a place to live, just the fact that if you are dealing with some mental health stuff, that you might self-medicate by starting using substances, and then your substance abuse comes into a physical health problem, and then all three of them are in there. And once somebody gets to that state, how much harder it is to get them back to a place of stable health. And with that, I will pass.
Thanks, Brian. I appreciate that. It's interesting when I talk about respite or recuperative care, usually the sort of example I use is a very simplistic one of, if I fell and I broke a leg and I had to have surgery, and I then have to carry everything around with me and I'm on crutches and I recently did that. I fell and broke my leg. And so if you see me periodically putting my foot up, but I will say you're exactly right. I have a nice warm bed. I have a support system. Somebody's bringing my medications, my food. My recovery is definitely probably on the optimal side versus somebody who's not. So I appreciate you bringing out those things. All right, Brian, I'm going to aim this one back at you again. I'd like to hear from you. Being on the ground, you have kind of a both and. You have done direct service on the ground, and now you're kind of at that more systems level. So we've touched on how various systems can negatively impact individuals. What has success looked like for you in moments where stability leads to better health, or taking care of health allows for housing securities? So what's worked? What have you seen as successful?
I've been thinking about this since Mike Rios reached out to me, and I would hate to have to say this, but I was at Taco Bell the other day, and I was ordering my food, and they asked me what my name was, and I said, my name is Brian, and the person behind me, who I didn't see, said my name, and I turned it around, and it was a client I knew back from Simpson Shelter probably about 10 years ago. This gentleman had some severe mental health issues. I had to ask him to leave the shelter many times, and when I saw him, I thought maybe possibly that he might attack me, because he and I relationship was very rocky, and the way I didn't enforce the rules. And he just said hello, and I asked him how he was doing. He said he was great, that he had been had a place to live, and I said, life treating you good? And he's like, life is treating me great. And he asked me if I remembered another guy at the shelter, and I said, yeah. And he's like, well, can you mind if I tell him you say hello? And I said, yes. And, he shook my hand, got his tacos, and he went on his own way. And the fact that this is somebody that when they were homeless, out on the streets on a day-to-day, their mental health was not addressed. Their chemical health was, on the high end. And now this individual has been housed for several years. And I could definitely see by the way he was dressed, his interaction with me, and just overall, even his interaction with the people at Taco Bell some years ago, I didn't think that would be a positive interaction for him due to his state of his mental health. He was able to do all those things. And I think that, the fact is, I don't know who told him or anything happened with him, but the fact that he was able to increase his health or address his health issues just by having a roof over his head is something that we all should be striving to do. And I have many other examples of things like that. And I think that that we need to be knowing that, you know, like we were saying, like the way you're able to take care of yourself right now, Danielle, in giving people the opportunity to do that themselves. So with that, I will let someone else speak up from there.
Well, I'd love to hear success stories, even the happenstance, and I won't say anything about the Taco Bell, I promise. All right, anyone else, if you'd like to chime in and don't feel like you have to, thinking about things that you've experienced or seen that have worked well to help people move forward.
Go ahead, Diane.
And don't feel like you have to, because I can also ask about quality of housing. I'm curious, if you have examples, please do. But I'm curious about quality of housing, and if anybody has thoughts on quality of housing and what impact it might have negatively or positively on health.
Well, Danielle, if I could go back to the success, just what does success look like? I shared also with Michael when he reached out. There's in our area for many years, you know, the standard of care for people that have been chronic alcoholics, a substance use disorder, have been really not to provide respectful, stable housing for folks. An organization up in northeastern Minnesota, Center for Alcohol and Drug Treatment, I happened to be working with them at the time, had the bold idea at the time to say, let's have a facility where people will be able to live in a dignified, safe, respectful environment. And we are not going to have the rules that they can't drink, like many of the other places had been up to that point in time. A lot of resistance from law enforcement to community members to say, why would you have housing for people if they're not going to stop drinking? It's like, well, because they're running, you know, all sorts of things between detox, hospitalization, so on and so forth. Long story short, it was built with over the resistance of much of the community. And what people found is folks had a stable, safe place to live. They were able to reduce their substance use disorder, their chemical use, 90% reduction in visits to both emergency and detox, interactions with the police. The stabilization led to a much higher rate of success of transitioning and being able to, through harm reduction, be able to have much healthier lives. So it's just a direct correlation between let's have a place for people to live, and then just the kind of metamorphosis of what would happen for folks on the health side of their life. So that's one example of what success can look like.
And I can share, I suppose, something a little bit similar to, definitely want to recognize some of my colleagues who are on the call here across our health system. And there have been a number of partnerships, including with Catholic Charities and other organizations, as we think about the ways in which we understand our continuum of care and the support that our patients need, and, you know, sort of the limits that we have as we think about extending out into the community. But one of the programs that we have been able to pilot over the years has been the Coming Home program. And that is really for individuals experiencing chronic homelessness, to reduce emergency visits and frequent inpatient hospitalization. So some of what you were talking about earlier, Danielle. And so that partnership allowed us to make direct referrals out of St. Joseph's Mental Health Unit to a case manager at Guild. And then in partnership with Hearth Connection, there would be wraparound supportive services, as well as that search for housing for those who are Medicaid eligible. And so it's been a smaller number, certainly, of participants, just given the case management side. But because of that, we've been able to see as of August 2021 that, you know, 10 participants had been housed for at least some period during the time frame since the start of the program. And then specific to some of these pieces, we're talking about health and, you know, the best use of healthcare, that we saw this 87% decrease in the number of emergency room visits after enrollment, an 88% decrease in the number of inpatient hospital visits after enrollment. And then that 72% of the participants had been connected to a primary care provider and to a psychologist or therapist as appropriate. And so certainly seeing, positive experiences for those patients who expressed that it was such a foundation for them to be able to pursue their next steps and dreams, sort of what Brian experienced hearing, which is a really nice story. And then also just thinking about the reduction in cost for our other, common goods related to the reduced cost for law enforcement, for shelters, and for hospitals, and then for participants to be more engaged and active in their community. So thinking again about those medical respite programs and the decreases in ED visits, readmissions, and then the savings, cost-wise, certainly personally for individuals and families, but then to our greater community as well, so that we can make those positive, proactive investments in other needed parts of our community as well.
I appreciate those comments. It makes me think a lot about the sort of concept of housing first, which really speaks a lot to what both of you guys were talking about, which is the old mantra was people needed to be sober and mental health kind of under control, and have all these things in place to be housing ready, versus flipping it kind of on its head and saying, well, maybe if we give people housing and then offer support services and allow them to kind of have some autonomy and understanding how housing can change what they need and want, allows a lot of other flexibility. And also, I think that, Diane, you brought in a good piece around how multiple sectors can come together to really serve people. So I appreciate that. All right, Dave. And I think Diane also did a nice transition around mental health there too. So you have a background in therapy and psychology. Curious if you could tell us a little bit about how you see mental health intersecting in what we're talking about today and how it might impact the cycle.
Sure. When you think about your own mental health, in times that you've been significantly challenged or stressed for extended periods of time, and you add to that the uncertainty of not having enough food or many other basic needs being met, add potential threats of abuse or history of trauma or chemical health challenges, while also trying to navigate finding a safe, reliable place to live. You can see that even from our own personal experiences times 10, how our mental health and how people's mental health can be greatly impacted. We all know, or I'm sure most people know, that people with mental illness are disproportionately represented in our homeless population. On the other hand, in keeping with some of the other things we've already been mentioned, with housing stability, we know over and over again how mental health issues can be positively impacted and effectively addressed. So it's just, it's part of the prescription for good mental health is good housing.
That's amazing. Do you want to work together? That would be super fun. Diane, any thoughts about how you think about equity in this space, or disability, ability?
Well, I'll definitely build on what Dave had shared as well. I think certainly we, recognize the challenges for folks experiencing homelessness as it relates to their health and health care, but then want to think about that corollary in terms of health issues being a cause of homelessness, right? What are some of these root causes? And so ongoing health concerns obviously make it difficult for people to maintain regular employment. They may miss work or take unpaid medical leave, and then there's greater difficulty in performing normal job duties. And then once someone is unsheltered, existing health issues can worsen, and that makes it difficult, obviously, to regain employment. And so as we think about breaking some of these cycles and thinking about home, yes, but also just spaces and places that provide some sense of stability, one significant, but maybe small in this conversation way that we've chosen to respond is, for instance, our M Health Fairview Southdale Hospital opening Minnesota's first empath service. So that's the emergency psychiatric assessment, treatment, and healing service. So it's a pioneering model that has that rapid comprehensive care in a calming therapeutic space, and then staffed with teams of licensed mental health professionals. And that opened in March 2021. And, you know, in the first 6 months, what we've come to see is that we've seen approximately 1,100 patients that had received care in that unit. And historically, 40% of patients who arrived in Southdale's ER or ED with mental health systems with symptoms were admitted to inpatient care. And that rate is now less than 20%. And so, you know, empath alone isn't going to fix the mental health crisis or housing stability, but just in how it is that we even start to integrate these ideas of stabilizing, of creating comfort, of bringing in some of these elements of what is calming and what is culture, that we start to embed some of those principles within the spaces where we care for folks that otherwise might, you know, contribute to heightened anxiety and stress as folks are trying to seek support. And so a different kind of parallel, but just wanting to think about the many different ways we have to improve our ability to help folks feel calm, connected, welcome, wherever it is that they're receiving care.
Well, that's fantastic. And I think really touches on this idea of what is the right space for the health systems, right? If we're not going to sit around with buckets of apartment keys, how do we start to pivot and think differently to be a good partner, but also to change the services that we deliver and thinking about how we do that. So appreciate that. We're getting out. This is such a great conversation. We're getting a little behind, but that's all good. I love it. So actually, Diane, I'm going to stick with you for a second. We have a question here that touches really about some of your work on the equity space. We have a lot of research and we have a lot of communities that have helped us understand that we continue to have disparities when it comes both to the systems of healthcare and housing, especially along racial lines. Both housing and healthcare systems are certainly wrapped up in the work of equity and racial justice. But when we talk about equity, we often talk about access. So what barriers do you see when it comes to equitable access to healthcare? And how do you see that relating to housing access or affordability? Where might we see some things that need to be changed and how this impacts different communities and populations? Big question. Let me know.
Yeah, lots of big questions. Yeah, I mean, I think the general gist of it is that access is an issue, right? And that's part of the ways that our systems are built, and that we need to create opportunities for navigation and extension, of course, translation, and that there are needs and opportunities to redesign some of these things, right? And hopefully to do that in partnership with community, where some of these solutions will be best created or co-created. I think, as we take a step back, it's first thinking about health equity or health justice. And as we think about our health system, one of the ways that we felt convicted to respond following the murder of George Floyd was really taking a hard look at ourselves in the mirror to say, what is it that, our health system and health care in general has contributed to disparities, to structures that have excluded and that have perpetuated this harm. And what do we need to do about it now? Or continue to do, because there have always been people, obviously, within our system who are heroes and who have been compelled to do this work. But structurally, how do we do this in a way that is more transformational? And so we've had the opportunity over the past year and a half. I serve as one of 3 HOPE commissioners, and that's our initiative to, across our joint clinical enterprise, consider how our healthcare system looks at the ways in which we can improve diversity, equity, and inclusion culturally and education-wise, but also equity in terms of the healthcare we provide and the way in which we show up as a community member, as an organization with our assets and our platform. And so we have structured it so that, when we think about our employment and the opportunities for people to come in and work in their neighborhoods and to progress in leadership and to have our employees reflect their communities, and knowing, right, that is based in evidence that it increases patient outcomes of experience and health equity, that through the work of healthcare provision that is more culturally centered and reflective of and representative of patient experiences, in our work as academics and in the research and the extension of clinical trials and opportunities, or the learners that we draw here to be able to eliminate health disparities. And then the way we do everyday work, right, of that hiring, but also investment and purchasing. How are we actually helping to contribute to building wealth in our communities? And certainly that's wrapped up in the conversation about housing, is building wealth, particularly for communities that have been disenfranchised and marginalized from those opportunities, so that it can sustain, and that can be what helps to lift up. And so we've tried to take that broader view, and as we think then about equity in all of those different spaces and access in all those different spaces, there's a lot to do. But, you know, Dave talked about the priorities for their health needs assessment. Certainly navigating and accessing care and resources has been a key one for us across our hospital communities across the state. And so that does look certainly like access to brokers that help to navigate some of these upstream challenges. You know, when I think about housing, I think of some of our cultural brokers who have been asked by their clients. These are full-time, bilingual, bicultural, you know, employees of Fairviews that we then embed within different community organizations where they are, you know, trusted and able to access these resources, hopefully before things become an emergency. And the difference between a client trying to call to get an extension on their energy bill payment or a utility bill payment and not being successful, whether because of language or because that was just not a chance they were being given, but then having someone call that cultural broker, you know, with that Fairview name and, you know, in English, that the ability to advocate and to navigate systems for folks who otherwise are going to be excluded, that I think is part of the work that we need to do to be able to extend that, that broader circle of inclusion. Because housing, obviously, just like education, housing is just tied to so many things, right? That zip code, what are the schools? What are the opportunities to recreate? Where are there parks? Where are there healthy places to get food? And, you know, neighbors that you trust, and how is it that we can create that opportunity for folks who otherwise would be then cut out from those resources, and that gets compounded over time. So I think just broadly, to answer the many questions you had, we do need to take that broader view and know that it is our obligation and responsibility, and that as we apply those changes over this time horizon, that is transformative, but also starts to make some of these fundamental shifts day by day, year by year, that we think of it holistically, because housing is one of those social determinants of health, and it's one aspect very key to who we are as people and how we feel supported and connected to our communities.
Amazing. So yes, I asked a complex, layered question and you gave amazing answers. I really appreciate it. All right, last, Dave, I'm going to throw you a quick one here because I know we want to turn it over to make sure that we have time for questions from the audience. I'm wondering if you could give us a quick thought on where you see equity and inequity, specifically as you think about reentry from criminal justice systems and how it impacts ability to access both healthcare and housing.
Sure. You know, I as I'm sitting here, I'm thinking, you know, as a society, if we think that investing in adequate housing is expensive, not investing in it, as we all know, is even more expensive. And I think in the criminal justice system, that's just one example, let alone in the healthcare system and chronic conditions and so on. You know, we see a lot of folks that are, you know, just living in riskier environments, you know, leading to more involvement with the criminal justice system. That alone really limits some of the opportunities for housing once they get out. So we continue to struggle, and we work very closely between human services and the court system and people within the justice system and a lot of community-based organizations to try to find housing that is going to allow for that support, to decrease the opportunities for probation violations or maybe new offenses or whatever. It is so difficult, as many of you know, to be able to have folks qualify for housing. So what we find is we just see that revolving door over and over again when we all too often are setting people up for failure by not having adequate resources. So that's just one more area where we have to really change. Our paradigms has to significantly shift to allow for more success in that area.
Well, and thank you for that. Again, a really nice drawing of various intersections in different sectors where we could all come together to do better. So I want to thank all three of you. Amazing conversation. And Mike, I'm going to turn it back over to you because I know that you're sort of fielding a lot of the different questions and hands raised and things like that. I want to make sure we have plenty of time. So thank the three of you so much. I appreciate it. And we'll turn it over. Thanks.
Great. Thank you, all four of you. We are going to open it up. I've already got some questions to start that have been coming in. But the way that we'll do this is if you have a question you'd like to ask in person, you can locate your virtual raise your hand button under the participants button. So you can find where it says participants, the little people. You can click that, and then at the bottom of that screen that pops up, you should be able to see raise your hand. So once you raise your hand, you'll be put in a queue. We've got 125 folks. So we'll keep this orderly by just going in order there and alternating between the questions that have been in the chat and those who want to ask with your actual voice. So we have some to start with. So I'm going to start with you, Brian. First question that came in. Danielle mentioned you doing culturally competent or culturally appropriate care. How do you see that play out in your work, and why is that important?
Well, I always think that, if somebody has someone they can speak to that they feel comfortable with, definitely first off with the trust component of it. I think that, no matter where somebody's coming in, feeling like they can trust and have an open conversation with somebody to build that rapport to get their questions answered is a good way to start. And I feel that having a well-educated staff who are well-trained and who are there and willing to work with anybody who comes to the door is the first way to start. One thing that I know that my agency can do a better job with when it comes to those things is just having some more people who speak more than one language. Being to ensure, I had someone call today who had a client that is deaf and hard of hearing and needed some sign language help. And luckily that client comes with some services themselves already to make sure that I could communicate with them. But just making sure that, we have the appropriate way to communicate with everybody and having open door policy to work with those coming through. I think it's the biggest thing to do so. And then making sure that a little something about the people you're working with to be culturally, appropriate, right? And making sure that you're treating people in a respectful manner that where they come from is considered respectful. And that's a broad spectrum. So it's not an easy one in today's times, but it's also a very doable thing to do.
Yeah, absolutely. So I've got two questions here that I think play into each other quite a bit, and I'm going to direct this at anyone who has a thought, but certainly the folks who are in the healthcare system might have some opinions here. But the first is, would a single payer insurance assure better and timely healthcare? And the second question that I think goes with this is, what are concrete ways that healthcare systems and payment models can help solve the homeless/healthcare crisis? How can each health plan contribute to these solutions? Just solve that right now tonight.
Well, I'm gonna think a little bit about that second question, Mike, if you don't mind. So I started to think about the way that the Affordable Care Act and things even before that helped us reframe how healthcare is reimbursed. So if Jimmy Joe hits the ED 10 times and I get $1,000 each time, it's hard to think about investing in systems that maybe change that. We have seen a shift in what we think about as value-based care. And from a health systems perspective, it's essentially incentivizing common sense and the right thing. So if we help people get connected to the right services, if we help people stay healthy, if we help them have quality outcomes with their chronic conditions, maybe we get paid differently to do that. And so I think really flipping on its head the ability to think about how we quantify what is good outcomes helps us think about then where do we start to invest differently. And so specifically in the case of insurance companies or payers, when we start to think about those quality outcomes that everybody wants, right? The health system and the payer, and how do we think about reframing it so that we're all sort of in a win-win space? You might actually think about incentivizing things like social workers and nurse coordinators and community health workers, or even more, like let's get more innovative, let's get more transformative. Some of the things that Diane talked about, or thinking about how we could pay for things like recuperative care where there's a win-win-win. So I'll just pause there.
I'm glad you got a chance to be a panelist too, Dr. Robertshaw. So I can speak maybe a little to that second question. You know, as I referenced our efforts to serve as an organization or institutions anchored in the communities where we are, that really allows us to think again about our ability to help build community wealth. And so how is it that the things that we need to do for everyday business practices anyway can invest in, you know, BIPOC owned, locally owned companies, and in terms of where we're buying our food, right, for our food RX programs, et cetera. And so part of that is just thinking about where we invest our dollars through certainly community contributions, but also how we leverage our financial assets. And so we have been in conversation with our board around directing some portion of our investable assets, those unrestricted assets, to community health programs in partnership with our community organizations and leaders, such as community development and affordable housing projects. And so we're excited that there has been some board action recently in support of that. And now, you know, are working with our treasury and investment teams who are putting together those details. So we are eager to share more as those strategies take shape. But, you know, hearkening back to this idea of taking that more universal or larger frame, I should say, it is really about the opportunity to think big and to think about using these significant assets, given our size, in a different way. And so we're still newer in it, but luckily, you know, as part of the Healthcare Anchor Network, you know, a collection of healthcare systems and hospitals across the country who have committed to doing this kind of work, we're in good stead and have the opportunity to learn a lot. And we're eager to be able to do that here in Minnesota, in the Twin Cities.
Wonderful. Thank you. So we have another question here, and for those in the audience, feel free, you know, I mentioned that this is a community event, so you don't even have to turn on your camera if you'd like to ask a question. Just raise your hand. You can use your audio, but feel free to raise your hand and we'll put you in the queue. But I have a few more here. So this question is, I think about both your work in public health, Dave and Brian, in the community, talking with people not just who are in need of services, but people who are in neighborhoods and who will be neighbors to these individuals. But what are good ways to convince communities that are hesitant to have affordable housing in their neighborhood that it is good for everybody?
Well, I can take a stab at that. We have been successful in overcoming some resistance in some areas. You can find champions in those neighborhoods that can speak to the benefits. You know, there's so many different ways to look at what success is, and there are so many examples out there. And I think folks, if they have a neighbor talking to them, or they have somebody right from their community starting to advocate, it's finding those champions, building on successes that are located in other areas, and showing what it really can be a win-win. And there's so many different angles from it's the right thing to do, but just from an economic standpoint, if that's the angle you have to take, it just makes sense for folks. But it makes for stronger communities. But I guess I would start with finding those champions.
I think that I would say that, you know, I think about something that I used to say when I spoke at the memorial service every year at Simpson, that everybody's somebody's one of three people: somebody's mother, brother, sister, aunt, uncle, father, right? So they're everyday folks, right? And we need everybody in the community to be a whole. We need a diverse community, and we need a community that is welcoming to everyone, right? And just because somebody does not have a home currently doesn't mean that they're going to be a bad neighbor. In my years of doing this, I've seen folks who I can think of this guy who was probably one of the biggest alcoholics I've ever seen, had the cleanest house I've ever seen in my life. Never had any problems with his neighbor. He always had cake. I mean, like things that you would not think of, like when you saw this guy in the shelter, that he would be doing that. All his neighbors knew who he was, and that he was just all around just nice guy. He just struggled with his own battles with alcoholism. Does not mean that he's not somebody who can be a good neighbor.
Any other thoughts on that one? Okay, we have one more before the final question. So one more from the audience. And again, kind of looking at health systems, but also Dave, from local government. I'm curious your take. Can you talk about the financial implications of truly considering housing as part of healthcare? Who will pay? How will we incent payers to support housing, especially big private payers? Are we generating the kind of data that will be compelling for public and private payers?
Yeah, I can certainly start. I would guess that my argument would be is that we are already paying. We're already spending way more money than we need to, and if we're not spending it correctly, we're not spending where it's going to have an impact. And I think data is being collected. We're not investing in the right places. So I guess that's where I would start.
I would also throw in there, like, last time I checked, and this was some years ago, but it was about $1,500 for a 3-day stay at Detox. So we could if somebody had a stable place to stay and not be utilizing those resources, we're using that money to put in other places that we can lessen the cost of, from someone to have a place to live in, and spending wasteless money on things like Detox.
No, I guess I would agree. I think that the time is right to say we've got all these various pockets, and sometimes the money's in the wrong pocket, but we're at the space where it's time to start to shift. As people have mentioned, there's a lot of incentives for insurances or payers to think about what do we start to invest in differently, and maybe the right space and the right place to help move things forward, and also spend the money in the right place to support people.
Great. Okay, well, the final $1 million question for each of you, if you could succinctly speak to this. What are, from your lens, from your particular lens, what are things people or organizations can do to help break this cycle between poor health, housing insecurity? What are things that individuals or organizations can do to further this work? So I will start with Diane.
Thank you. Yeah, I mean, it's just very complex, and something I think as I'm watching the chat too, right? I'm so grateful to how many folks are so invested in and working on so many different strategies for all of this. And so, I want to shout out Eric Muchler and some of the work that he's helping to lead to with these conversations. But, I think it just housing as a strategy for health and healthcare just cannot be understated. And so all the ways in which we can support systems, investment, and then individuals who are trying to navigate all of that, right, to the extent that there are really intensive needed services or the supports to just help translate and interpret and create a fairer and more relational dynamic for folks who are seeking housing. That those are some of the broad strokes of what we need to be able to do, and to understand how it is that we all contribute to that. And so I think from the perspective of our healthcare system, we are trying to use a variety of approaches in how it is that we can deploy our, employees' passions and time and commitment around this, supporting the Habitat for Humanity board, contributing to some of the builds that are happening, supporting Catholic Charities. certainly raising our voices about the needed political and community will, whether it is about welcoming to the question that was asked earlier around affordable housing in our neighborhoods, in all of our neighborhoods, and that voice at the legislature. So thinking about the work Catholic Charities is leading even now. And so being able to plug in again at a systems level as well as an individual level and that program level. So those are our efforts. We know we're at the start and we're eager to continue to be part of these bigger conversations. So want to just say thank you as I conclude here to all of you as passionate advocates and to the partners here around the table who I know will continue this conversation and work beyond tonight.
Thank you, Diane. Dave, if you had one thing to share with folks as you send them off.
I'd go back to what Dr. Robertshaw started out with. It's a human right. I think through public-private partnerships, we can get a lot done. And I think both the public sector and the private sector need to step up the plate and partner because it is human right.
Thanks. Brian, a word of invitation for folks as you leave.
I would get folks to think about a diverse housing resources for those that are currently homeless, instead of just putting all of our thoughts and efforts towards housing support as our main way of getting people out of shelter into housing. I also would encourage people to look at the way we do shelter and the way we do housing and think about a transitional model to get people those resources and health things that they need so that they can transition into the community and be successful and stable. I think that we've done a lot of good work housing people over the years, but we also see a lot of those people returning back to the shelters due to not being prepared to live in the community on their own with just case management services once a week. I think that we're not doing justice to some of those individuals and making sure that we're getting everybody the whole gambit of services from mental health, chemical health, and physical health services so they can be a strong individual once they are housed in the community and have a good relationship with not only their landlord, but their neighbors. Thank you.
Wonderful. Thank you, Brian. And Danielle.
I know our audience probably comes from a very diverse background, both personally and professionally. So I will say, be willing to innovate, be willing to find new partners, bring your subject matter expertise to the table. Don't think it doesn't matter. I think it's going to take multiple systems and multiple humans to kind of help solve this problem. And I say, as an individual, just don't forget, I think Brian's idea of 3 degrees of separation. Everybody you encounter who's experiencing homelessness is somebody's important person. So I guess just don't forget to smile.
Thank you very much. And thank you to our entire panel. So grateful for your time, lending us your lens and your wisdom tonight. I'm going to put in the chat one more time. I invite you to reflect on these questions that I put in the chat. If we were in person, these are the questions that I would ask you to turn to your neighbor and share and talk about. But maybe there's something you talk about with an important person in your life tonight, tomorrow at the dinner table. Please continue this conversation. And before we leave, I will invite our fearless leader of our social justice team, Wendy Underwood, to close us out and to send you off.
That's kind of you, Mike. Really great job to you and the woman behind the screen, Lily. Thank you so very much. As Mike said, I'm the Vice President for Social Justice Advocacy and Engagement at Catholic Charities, and I have had the privilege of knowing each of our panelists through work and community engagement. And so I just have been so excited for tonight once I knew that this group would be coming together. And oh my goodness, I think the chat just really spoke to just how inspiring and interesting and curious you have helped people be tonight. So I just want people to jump onto their reactions button and just one more time thank our panelists through hands and hearts and claps and just to express our gratitude for your thoughtful time. And I had the unenviable task of wrapping things up, and because there's so many great, wonderful threads to run with from tonight, but something I share with some of the panelists is that in my role, I get to talk to a lot of different groups about the wide array of Catholic Charities services, our needs, and importantly, the people we serve. And one of my responsibilities I take super seriously is to help shine an honest, transparent light on the very real, complex challenges in our community to audiences of people who it doesn't always cross their desk, it doesn't always occur to them. I spend time on boards with a bunch of architects because Catholic Charities has 500 residents in the area that they're developing, you know, and so it's my job to really help people see and understand and care about the people we serve, that they are really our neighbors, moms, dads, kids, as Brian said, good neighbors. And, you know, and real people have real ups and downs. They have challenges that are made exponential by the presence of poverty or even the threat of it, as we just discussed a lot tonight. And struggling with very real health challenges while also not having housing stability, it can be hard to understand if you haven't been there or haven't supported a family member in that situation. But it also is very, very simple. I think Brian's example
Wendy, you're on mute.
Oh yeah, I just saw that. Weird. So I just wanted to just finish by saying that the example of multiple sectors coming together, like here and all the other voices in the chat, I mean, it's about coming together, and it doesn't have to be hard. We just have to be willing, right? And I think recuperative care is an amazing example of that. The partnership that came together for the Recuperative Care Center in St. Paul, and then the incredible 30-bed program that will be opening this summer at Elliott Park under the leadership of Dr. Robertshaw and a number of others, is truly about doing, I mean, it's not hard when it's right and when we're willing. And so lastly, that's where each one of us comes in. And there are very, very real things we can do starting tonight, seriously, that ensures this conversation continues. Literally, when you're done here and you're, wrapping up for the evening, checking your text messages or visiting with family, tell them what you've been doing. Tell them about this conversation and what you've learned or what you didn't learn or want to understand better. That is advocacy at its core, is telling the person next to you what you've been learning and thinking about and want to work on. This event is recorded, and it will be on our website along with all of our other resources to help people learn more and support these challenging conversations. But I promise if you talk about it this evening with just a couple other folks, you have inspired people just like we are all inspired tonight. You can definitely experience a little bit of what we've been talking about by volunteering at Catholic Charities sites across the metro, just one shift. Someone we love who works with us says $1, one shift, and I say one vote. But it's easy to do, and it's a way to meet people and learn and experience. And then, of course, you can act. It's been in the chat all night tonight, but no kidding. On your cell phone, just text the word home to 50457, and you'll sign our petition all about the power of home, calling for housing stability for all Minnesotans. It's calling for that political will that Diane raised and the willingness to change old ways, as Dave and Brian have been talking about. You can also go to our website, which is going in the chat, cctwincities.org/advocacy, and you can sign up there. It's easy, it's free, it's powerful and impactful, and it's added to the difference that this conversation did tonight. That's it for me. Thank you all so very, very much again. Really appreciate you.
Thank you all. Have a wonderful night. And once again, we appreciate you joining. Take care.